that is caring for a 54-year-old female patient on the first post-operative day after a Roux-en-Y gastric bypass surgery. Which assessment finding would be reported immediately to the surgeon? Now let's think about this. The patient has bilateral crackles that are audible at both lung bases. Would we expect that after surgery? Yeah, it might not be a complication. It's something we need to do some nursing care about. But think about it, they've been under anesthesia, so they've not been breathing deeply on their own. They've been on machine during surgery that's been breathing deeply. They had abdominal surgery, so they're not going to want to take deep breaths. So if we get them breathing deep, we may be able to open their lungs back up and get rid of that, those crackles, okay? We also, there's redness, irritation, and skin breakdown in the skin folds of the patient. Is that something we need to call the surgeon for right away? No? Yes? No, because that's normal with obese people to have some skin breakdown. We would want to put something on it, and we would want to talk to the doctor when we see them or when we're calling them, but it would not be something we needed to report immediately. Emesis of bile-colored fluid past the nasogastric tube. Patient has an NG tube. If that's coming up around the NG tube, what does that mean? Blockage. The NG tube's not working. We want the NG tube there because if the person, it's there to take those stomach contents, that acid, that gastric acid, out of the body and get rid of it to keep the patient from throwing up, okay? Because that's going to come up. The stomach's not awake yet. It's not moving through the patient. There's no motility there, or very little motility in the stomach. So those gastric contents cannot move through the body. So we keep that in there until the stomach wakes up and they can move through the body so that we can start feeding them and letting them drink. But if that's blocked and it's coming up around the tube, then we need to call the surgeon. One, because we don't want to mess with a G-tube that's had an abdominal surgery unless we know what we're doing. And we need to get that unblocked because we don't want that patient throwing up, right? What happens when you throw up? They can aspirate. Big problem here is, though, they just had surgery in their stomach. We don't want to increase that intra-abdominal pressure and possibly pop some stitches or sutures or staples, okay? So we want to make sure we don't have a patient who's post-abdominal surgery throwing up on us if we can help it. And then use of a PCA several times an hour for pain. That's what we expect. We expect them to be using their PCA pump. Now, if it said using the PCA pump several times an hour without relief, then yes, we would want to call the surgeon for that. But we expect them. That's why we get it, so they can use it. And they can't get it more than what it's set for them to get. So, okay, post-operative interventions. We want to monitor vital signs of these patients very carefully and very diligently because fluid status, we can tell fluid status shifts from vital signs. Remember our blood pressure, our heart rate, sometimes even respiratory rate can fill us into that too. Those crackles in the lung could be a fluid thing. You know, if we can get after surgery, sometimes in surgery they give a lot more fluids and we need to get those fluids moving. So we want to monitor eyes and nose. Very important after surgery. What is one big thing that people have trouble doing after surgery? Peeing. They have a lot of trouble with that because the body, you know, it relaxes all the muscles or paralyzes the muscles. Your bladder muscles are included in that, so it takes a while for all that to start working correctly again. You want to make sure you assess bowel sounds. They're going to want to keep the NG tube in probably until those bowel sounds start or the patient starts passing gas. And you don't want to feed someone who does not have bowel sounds because it's just going to come right back up. Monitor the NG tube as ordered. If you have an order to flush it, you can flush it. You don't reposition it or anything after an abdominal surgery without the physician present. They should be the ones doing that if it's an abdominal surgery. Usually they're in PO for 3 days or until that peristalsis starts back up. Now we're doing a lot more of these surgery laparoscopically. So the patient, it's a shorter surgery and the patient's not under anesthesia as long. So usually it doesn't take as long for the stomach to wake back up and start peristalsis to begin. So it's a lot better. They don't stay in the hospital as long. They don't have to keep the NG tube as long. They can start eating a lot faster. But those are things that have to happen. Now, after a gastric bypass surgery or a lap band or any type of weight loss surgery, they are going to be on a very, very strict and restricted diet. So it will be like 10 cc's or 15 cc's of fluid, every 2 hours or something. I mean, it's like really, really restrictive. Not only what they eat, but how much. And then, of course, you're going to want to do good pain management for them. Okay, early postoperative complications. You can see DVTs, PEs, bleeding can be a complication. An anastomotic leak, so where they hook the 2 pieces together of the bowel or the GI system, you can form a leak around it. There can be cardiovascular or pulmonary compromise. Later complications, dumping syndrome, which is a huge one, and we will go into that a little bit more. Diarrhea, which can occur from dumping syndrome or just diarrhea. Dehydration, because they're not allowed to get much fluid. Or hypoglycemia. So hypoglycemia because their food intake is really, really restricted. We talked about the deficiencies already. So let's go to B12 deficiency. What you're going to see. That happens because B12 is absorbed in the intestinal tract. Signs are pallor, fatigue, weight loss, a smooth, beefy red tongue. Do y'all know what a beefy red tongue looks like? It's swollen and it looks kind of like you would think red ground beef would look like. Slightly jaundice sometimes, paresthesias in the hands and feet, and they can have gait or balance disturbances. Treatment, you give them B12 in the diet, but if they're not absorbing it, it's not going. If they've had an absorption, restrictive surgery, restricts absorption, then that's not going to help, so they're going to have to be on B12 shots. Sometimes they can absorb it from B12. I think they have sublingual B12 now also. Dumping syndrome. This is a really bad problem. Now, I will say with dumping syndrome, there are some suggestions for diet. There are also, I'm going to give you some suggestions for diet restrictions and things for a person who has had a gastric weight loss surgery. So the two have some contraindications, but just think of them as 2 different problems. Dumping syndrome is something that people have, but it's also very, very common after weight loss surgery. So it is when the gastric contents empty rapidly into the small intestines. It usually happens within 10 to 30 minutes after a meal, but it can be 1 to 3 hours depending on what type they have. Most often it's the 10 to 30 minutes after a meal. It can cause nausea, vomiting. It causes sweats, nervousness, anxiousness, diarrhea, palpitations, tachycardia, really bad abdominal pains, cramping. They get bloated, really loud borborygmus. Y'all know what that means? Bowel sounds. That's those really loud ones, like you could stand over there and hear it from somebody standing here. Dizziness, weakness. It almost feels like hypoglycemia with a really bad stomach ache. And I think sometimes people think, oh man, I have food poisoning, but it comes on so quick that it can't be food poisoning. So, but then there can be dumping syndrome that happens between 1 and 3 hours, and that one you'll get symptoms of hunger and you'll see symptoms of hypoglycemia that occurs with that type. So patient education, they need to avoid sugar, salt, and milk. They're supposed to eat a high protein, high unsaturated fat, low carb diet. Small meals will help. Avoiding fluids during the meal will help. They also tell patients with gastric bypasses to avoid consuming fluid with their meals. Avoid very hot or very cold. To lie down after meals because its kind of gravity helps it to stay in the stomach longer. And there are some antispasmodic meds that will help slow down the stomach. Yes?
Is this to prevent them from getting dumping syndrome, or do they do this after they?
After they develop it, but these are ways to prevent the symptoms of it and it occurring. Yes.
If it is down right after they eat, do you think it acts reflux? Or does it like benefit outweighs?
Right. You just have to pick it. And maybe not flat, elevate the head, but you don't want to be up moving around because that up moving around is going to increase peristalsis even more. Yes.
Just to that point, patients, gastric bypass patients don't get a lot of acid reflux.
Yeah.
That's the way they do that.
Right.
For those,
Right. It can happen with the bands, but yeah, but would be more complicated surgeries. Thank you. And I'll tell you with the medications, they work for some people great, and some people it's like candy. It does nothing for them. After bariatric surgery, weight loss surgery, they're going to be told they need to be educated to avoid alcohol and carbonated drinks. Avoid foods high in calories, and this is where with the unsaturated foods, you encourage it in dumping syndrome, but it's not allowed in bariatric surgery. So that's the difference there. So you wouldn't allow it you would tell them not to do that if they had dumping syndrome from bariatric surgery. They would not eat the fatty foods. Avoid sugary foods and drinks. Eat slowly, chew well, take nutritional supplements. They need to do their vitamins as ordered. The diet is very strict and it's very specific, and they need to follow that very specifically. And then monitor for signs and symptoms of complications. Don't eat and drink at the same time. They need to drink at least 48 to 64 ounces of fluid a day to stay hydrated, but it has to be just sips at a time. They constantly have to be sipping fluid. Any questions? All right, we have 15 minutes. So I want y'all to just pair up real quick in groups of, 6, 8. This is a quick case study.
I see.
All right, guys. I'm just looking at something because I gave mine away. No, you're fine. Y'all just need to share over there.
Do they not have one?
No, they
Oh, I'll just take a picture and then I can read it and they can see it.
Oh, okay. That's a good idea. You're so smart.
This should be the 70-year-old female. This is 42-year-old. I had a terrible start. This is the 42-year-old. For height, 240 pounds. Initial symptoms over the past weekend, this baby showed increased severe epigastric pain.
Yes.
That may have simply overeaten, but the pain is present even though she likes to do it. For the past 24 hours, she has also been additional information. Upon questioning, Papa reports that she has had 7 fans, current fans, very close. She is happy that it is because she has lost 42 pounds and her primary care physician has discontinued her blood pressure. She states that she doesn't believe that it's related to the gastric necessity because she doesn't feel sick. She is alert and states that the only reason she came to the ER is that her stomach hurts so much when she tries to what investigation for reason to take it forward.
Okay. Y'all read it?
Yeah. I haven't eaten. Great dad. Great good. You guys so well. It makes it proud.
Okay, guys. Let's talk about this for a minute. It's a pretty simple case study. Person comes in through the ED. Everybody listen? What are the symptoms? Stomach pain. When? When she eats. Does it say how long she's had her gastric pain? 18 months. Okay. So that rules out a recent complications, not, a post-operative complication. Okay. So, is that her only symptom? Vomiting. Okay, so she has some tachycardia. What did the tachycardia be from? Pain. It could be from pain. What else? A fluid deficit, dehydration. What? It could be from her not able to take in enough fluid, or her throwing up, or what else?
Not being able to get rid of.
I'm sorry? What else could it be from? Yes?
She's really overweight.
Okay, she's overweight and out of shape, maybe. Is there anything else? She's coming in, she's complaining of severe pain in her abdomen. see an obstruction? What else? Could she be bleeding? Could have had an obstruction. She could have perforated something. She could have a gastric bleed, right? Not necessarily. Depends on how recent it occurred. Her body could be compensating now, and they end up dropping the pressure really quickly after they start to decompensate. Or it depends on how bad the bleed is. The first thing you're going to see is the heart rate go up. Okay, so what of these labs, what are you going to be looking at? What's going to tell you the biggest indicators of what your problem may be or may not be? You've got a CBC and you've got a WBC. Okay. Okay, so CBC for the bleeding, your white count for the infection. Okay, so your white count is slightly elevated at 11.6, and your complete metabolic panel is normal. Everything else on the CBC is normal. What can we pretty much rule out, or can we rule anything out? Okay, so a CT maybe we want to get. It also says you've got a upper GI series ordered. What are we going to be looking for with that? Yes?
Whether or not it's grown into the stomach, or if it's too tight, or some other kind of obstruction as well.
Okay. Okay. And where it's empty, is it empty? What does that band look like? That's why they're going in there to see that. They want to see what the band looks like. So they go in and they do the upper GI series. We know there's some inflammation, infection, something, right? Because her white count is slightly elevated. Okay. So we can pretty much rule out a bleed, correct?
I apologize.
Is that can we pretty much rule out a bleed because her CBC is okay? All right. Okay, so we do the upper GI and it shows that she's emptying contrast around the band. So what does that mean? I'm sorry? Too tight? And it's eroded through. Okay, so kind of the same problem my friend had, but my friend waited a lot longer and was in a lot worse shape. So what are we going to have to do? Go in and take it out, right? You're going to have to remove it. Now, if you had this patient at this point, if it wasn't an emergent thing and she was stable, they would probably send the patient to the floor and plan the surgery. You don't want to do emergency surgeries if you don't have to, because you don't even want to have an emergency surgery if you don't have to. Okay, if you can wait safely, you want to wait, because it's better to have doctors and surgeons that are fresh and prepared and ready to go. You don't want to take the guy that's been working all day and now he's on call and that's who's going to do your surgery. Okay, so you want to kind of do it during the daytime when it's supposed to be done, and you have all the people there that know what you're doing. Now, they can very well do it at night, and it can be perfectly okay, or off hours, but if they can plan it and wait for that, it's always better to do that if it's safe for the patient. So we want to, if they send her to a floor to prepare, she's going to have surgery tomorrow, what would you anticipate the nursing care you're going to provide this patient?
With her anxiety, because it said that she really likes having the band, so if they have to remove it, she's going to be anxious for that, in addition to having to have kind of fairly emergent surgery.
Right. So anxiety.
Frequent monitoring, make sure that she doesn't, tank.
Decompensate, yes, absolutely. So frequent monitoring We don't want her, decompensating. And if she did, that would be something that would probably change the game plan. And, there's that fine line between they're stable, let's wait and plan it, and they're stable, and now they're too unstable to do surgery. We have to stabilize them. So there's always that risk, but, they have to wait. They can usually know what the big risk. And they look at the lab values, and they look at the vital signs, and they look at all that stuff, and they can pretty much tell what's going on with the patient. What else? What are some other things we're going to expect doing with this patient?
Do they make an NPO instead?
We want that patient MPO. We don't want anything leaking, anything more leaking, and we don't want it to mess up the ability to go to surgery. So it's probably even more important in this patient's case because we want him okay to go to surgery. What else? What kind of orders would you anticipate from the physician? Strict diagnose? Fluids. Probably some maintenance IV fluids. She's not eating or drinking, and she's already showing signs of a little bit of dehydration. So, what else? What are her problems? Okay, so she may need an antiemetic. Pain medication, yes. So we may need, I don't know if she's having pain if she doesn't eat, but we need to have something there just in case, okay? And then, yes, like, I think one of the first things you said was that plan, like what is the reassuring the patient that there are other things that can be done, and we have to get you stable and healthy right now, and we'll discuss options of what can occur. What can this patient do as far as bariatric surgery in the future? Yes.
That was kind of my question. So they're going to fix this problem and then later go back and do something different?
They may, if she's a candidate or if she chooses to, yes. As usually they'll take that out. Usually, I guess it depends on the physician and it depends on how bad it's eroded through. But the ones I've heard of, they don't go back and put another band on. But there are a lot of other options, and they're getting new options every day. So, another thing, they would probably do some type of preventative DVT. So some like heparin or Lovenox, something preventative. This patient won't be up necessarily moving around as much as normal. Okay. Any questions? Yes.
As far as being on heparin, if she's just had surgery, have they not done heparin?
No, we're talking about low dose heparin to prevent DVT, which they give local